a dietitian's perspective, critically ill patients are individuals who are admitted to the intensive care unit due to life-threatening conditions that require close monitoring and advanced medical interventions. These patients often have a high risk of malnutrition due to metabolic stress, inflammation, and altered gastrointestinal function. Conditions such as sepsis, trauma, major surgery, organ failure, and mechanical ventilation contribute to increased nutritional needs and complications, making nutritional support a key component of their care. Role in the multidisciplinary ICU and post-surgical teams by managing and optimizing nutritional support. Key aspects of dietitians' involvement include: first, nutritional assessment. By identifying patients at risk of malnutrition using screening tools such as Nutri-Score, NRS 2002, ASPEN or ASPEN guidelines, new GLIM guidelines for ICU patients, which will be published in Journal of Parenteral and Enteral Nutrition 2025, and monitoring the patient's body weight, muscle loss, and biochemical markers. Second, dietitians' involvement include enteral and parenteral nutrition management by determining the appropriate feeding route, enteral feeding versus parenteral feeding, and selecting the specialized enteral formulas, adjusting feeding regimens, and preventing complications like refeeding syndrome and aspiration. Third, usually dietitian will involve in the energy and protein requirements calculation by calculating the calorie and protein needs based on metabolic demands, severity of illness, and phase of recovery. Fourth, gastrointestinal tolerance and monitoring by assessing the tolerance to enteral feeds, example gastric residues volume, diarrhea, constipation, and adjusting formulas or feeding methods accordingly. Fifth, dietitian also involved in monitoring the electrolyte and micronutrient balance by ensuring the adequate intake of vitamins, minerals, and electrolytes to support wound healing, immune function, and metabolic stability. Six, dietitian also involved in the glycemic control monitoring by coordinating with the medical team to manage blood glucose levels, particularly in patients on parenteral nutrition or those with stress-induced hyperglycemia. Okay, another dietitian role is to monitor the weaning and transitioning of parenteral or enteral nutrition to oral diet. Okay, by assisting in transitioning from enteral-parenteral nutrition to an oral diet as the patient recovers, ensuring adequate intake and preventing refeeding complications. Okay, another role by dietitian is the collaboration with ICU team and nutrition support team in UMMC. Okay, I'm also an active member in the nutrition support team and working with the intensivists, surgeons, physicians, nurses, pharmacists, physiotherapists, and speech therapists to provide individualized, evidence-based nutrition care. Gastrointestinal dysfunction is highly prevalent in ICU and surgical patients, affecting approximately 30 to 70% of critically ill individuals. This variability depends on factors such as the severity of illness, presence of sepsis, type of surgery, and use of medication like opioids or vasopressors. Common gastrointestinal issues include gastroparesis, ileus, diarrhea, constipation, and intestinal ischemia, all of which can impact the nutrient absorption and overall patient outcomes. There are several factors contribute to gastrointestinal dysfunction. among the ICU and surgical patients, including first, critical illness associated changes, which involve the inflammatory response, uh, gut barrier dysfunction, and auto mortality. Second, um, is a hemodynamic instability. Okay, this factor can reduce the spasmodic blood flow due to shock, vasopressor use, or mechanical ventilation. Third is a surgical stress and anesthesia. And especially during the major abdominal surgeries, bowel resections, and prolonged anesthesia can impair the gut motility. Fourth, it can be the medications such as the opioids, sedative, proton pump inhibitors, and antibiotics can slow the motility, alter microbiota, and increase the risk of infection like Clostridium difficile. Fifth is the factors such as the delayed enteral nutrition, which some of the cases which prolong the fasting and delay the initiation of enteral nutrition can worsen the gut atrophy and increase the gastrointestinal intolerance. Another factor such as the sepsis and systemic inflammation can increase the gut permeability, bacterial translocation, and intestinal dysbiosis. All these factors I mentioned just now can contribute to GI dysfunction. Management strategies focus on early gut protection, symptom control, and optimizing nutrition delivery, including the first strategies such as early enteral nutrition. Initiating early nutrition within 24 to 48 hours when feasible to maintain the gut integrity and prevent atrophy. The second management strategies include prokinetic agents. Use of metoclopramide or erythromycin for gastroparesis to enhance the gastric emptying. Okay, another strategy is a post-pyloric feeding. Switching to nasogegenal or post-pyloric tubes in patients with persistent gastric intolerance. Okay, fourth strategy is the bowel protocols. Okay, regular assessment of bowel function with laxative enemas and also the motility agents for constipation. Okay, fifth management strategies include the probiotics and fiber. Selective use of probiotics and fermentable fibers in stable patients to promote the gut microbiota balance. Another strategy is to minimizing the sedative and opioids, reducing the opioid use when possible and using alternative like acetaminophen or multimodal pain management. Another strategy is the fluid and electrolyte management by addressing the dehydration and correcting the imbalance, example potassium, magnesium that affect the motility. Okay, monitoring and adjusting nutrition also important by tailoring the enteral nutrition formulations based on the tolerance, considering the semi-elemental formula in patients with malabsorption, especially for the critically ill patient and surgical patients. CPBCMC strains were selected due to their well-documented probiotic properties, safety profile, and potential benefits in critically ill and surgical patients. These strains have been studied for their ability to first enhance the gut barrier integrity by reducing the bacterial translocation and sepsis risk. Second, modulate immune functions by helping to control inflammation and improve host defense. Third, restore gut microbiota balance, which is often disrupted by antibiotics, stress, and critical illness. Fourth, by improve the gastrointestinal motility and reduce complications like diarrhea, constipation, and gut dysbiosis. Additionally, BCMC strains have been tested in clinical settings, demonstrating the efficacy in preventing infections, reducing hospital length of stay, and supporting overall recovery. Administration of HEXBIO MCP BCMC strains in ICU and surgical patients typically follow this consideration. First, route. Usually, we'll give a patient orally, if feasible, or via enteral feeding tubes. Okay, second, we'll consider about the dosage and frequency. Usually standardized based on prior clinical trials, ensuring sufficient colony forming units per day. And third, timing, initiated early in the hospital stay or post-operatively to maximize gut microbiota restoration. Fourth, compatibility with medications. Usually, we will ensure the administration is spaced appropriately from the antibiotics or proton pump inhibitors to prevent probiotic inactivation. Fifth, we also consider about the duration. Continue for a set period, usually to 14 days, based on study protocols and patient tolerance. The efficacy of a HEXBIO MCP BCMC strains in ICU or surgical patient was assessed using various clinical and biochemical indicators, including first indicator is a gut function matrix. We usually will check the incidence of diarrhea, constipations, gastric residue volumes, and signs of gut intolerance. And then also, so we also assess the microbiota analysis to see the changes in gut microbiome composition, including the beneficial and pathogenic bacteria. Third is the inflammatory markers, which include the C-reactive protein, CRP, and pro-inflammatory cytokines, example interleukin-6 and TNF-alpha, to assess the immune modulation. Fourth, usually we will assess the infection rates to see the occurrence of a ventilator-associated pneumonia, VAP, bloodstream infection, and Clostridium difficile infection. Okay. Fifth, we will also see the hospital outcomes, okay, such as the length of ICU or hospital stay, need for vasopressors, organ dysfunction scores. Okay. Six, we'll look at the nutritional outcomes, such as the nutrient absorption, okay, whether patient can tolerate the feeding or not, okay, weight maintenance and tolerance to enteral nutrition. Clinical outcomes observed in patients receiving HEXBIO MCP BCMC strains included: first, improve the gut functions by reduction in diarrhea, constipations, gastric intolerance, which can leading to better enteral nutrition tolerance. Second, clinical outcome is to reduce infection rates, lower incidence of ventilator-associated pneumonia, VAP, bloodstream infections, and Clostridium difficile infection. Third, modulation of inflammatory response. We can also observe some decrease of inflammatory markers such as the CRP, interleukin-6, TNF-alpha, suggesting reduced systemic inflammation. Fourth, some clinical outcomes such as the gut microbiota restoration. Okay. For this outcome, we can see the increased beneficial bacteria leading to improved gut barrier integrity and reduced bacteria translocation. Fifth, shorter hospital stay. Some studies reported a decrease in high ICU or hospital length of stay due to improved clinical stability and fewer complications. Six, enhanced nutritional outcomes, which we can observe the better maintenance of weight and lean body mass, particularly in prolonged hospital stays. Post-ICU and post-surgical recovery periods are critical for long-term health outcomes. While short-term use of HEXBIO MCP PCMC strain has demonstrated the benefits, their long-term use can be considered based on individual patients' needs. So usually we will assess patients' individual needs. Okay, usually we will consider patients with persistent gastrointestinal issues. The continued use may help maintain the gut microbiota balance, particularly in those with antibiotic-associated diarrhea or post-ICU dysbiosis. We also consider patients for general health maintenance. Long-term use may support gut health, immune function, and overall metabolic stability, but should be personalized based on clinical assessment. And for the immunocompromised patients, we still need to have more study to confirm the long-term health outcomes, because there are not enough study to support the benefit of long-term outcomes for immunocompromised patients. HEXBIO MCP PCMC strains aligns well with the enhanced recovery after surgery ERAS protocols by first preserving the gut integrity for the ICU and surgical patients. Early enteral feeding and gut microbiota modulation help maintain the intestinal barrier function, reducing the bacterial translocation and infection risks. Second, reducing the post-operative complications, such as the lower incidence of post-operative ileus, antibiotic-associated diarrhea and infections, example, Clostridium difficile ventilator-associated pneumonia. Third, modulating the inflammatory response by helping to control the systemic inflammation, supporting faster recovery and reduce hospital length of stay. Fourth, enhancing the nutrient absorption by optimize the gut microbiota and to improve the digestion and absorption, ensuring better nutritional status post-surgery. Given the ERA's focus on early feeding, minimal fasting, and reduced complications, HEXBIO MCP PCMC strain fit into the multimodal approach to improve patient outcomes while minimizing the hospital resource utilization. HEXBIO MCP PCM strains have the potential to reduce healthcare costs by first shortening hospital stay with a faster recovery, reduces the ICU days and overall hospital length of stay, leading to cost savings. Second, lowering the infection rate. This included decreased incidence of sepsis, pneumonia, and Clostridium difficile, reduce the need for expensive antibiotic and extended hospital care. Third, enhancing the enteral nutrition tolerance. Fewer complications related to feeding intolerance, prevent the need for parenteral nutrition and reducing the cost. Fourth, reducing the readmission rate by improving the gut health post-discharge. can lowers the likelihood of a hospital readmission due to gastrointestinal related complications. Overall, overall, integrating probiotics into ICU or surgical care may lead to a cost-effective approach that improves outcomes while alleviating the financial and logistical burdens on healthcare systems. Integrating HEXBIO, MCP, BCMC strains into ICU or surgical protocols across Malaysian hospitals is recommended, considering first, high prevalence of antibiotic use. In Malaysia, ICU or surgical patients often receive a broad-spectrum antibiotics and increasing the risk of gut dysbiosis and infections. Second, we also consider the potential to reduce infection-related hospital costs by reducing the ventilator-associated pneumonia and diarrhea, may lower the hospital cost and improve a patient throughput. Alignment with the ERAS and National Nutritional Guidelines can support the Malaysia's healthcare initiative focusing on early recovery, reduced mortality, and cost-effective hospital management. Both adaptability across the public and private hospitals. Probiotic use is relatively simple to implement without requiring major structural changes in hospital protocols. However, standardized clinical guidelines and training will be essential for widespread adoption, especially among the clinicians and dietitians in Malaysia. HEXBIO MCP, PCMC strains can be beneficial for the general population by first supporting the gut health, helps to maintain the microbiota balance, improving digestion, absorption, and bowel regularity. Second, enhancing the immune functions is beneficial in reducing the upper respiratory tract infections and boosting the overall immunity. Third, managing the metabolic conditions. Imaging the evidence suggests probiotics may help regulate blood sugar levels and cholesterol. Fourth, reducing the antibiotic-associated side effects. This can be useful in preventing diarrhea and gut imbalances after antibiotic use. For ICU or surgical patients require higher probiotic intervention, long-term daily use in the general population may support the digestive health, immunity, and metabolic stability. In clinical practice, HEXBIO, MCP, BCMC strains have shown benefits in various patients groups, such as the oncology patients with chemotherapy induced diarrhea and gut damage. There's example a patient undergoing chemotherapy experience severe diarrhea and gut inflammation. After use the probiotic, its outcome include can help to restore the microbiota balance, reducing diarrhea frequency and improving the nutritional status. Another patients group include the elderly patients with chronic gastrointestinal disorders. There are one example case, an elderly patients with IBS and recurrent bloating use the HEXBIO MCP PCMC for 8 weeks. It can significantly improve the gut motility, reduce bloating, and better stool consistency. Other patient group include post-antibiotic therapy patients. There are example for patients treated for pneumonia develop antibiotic-associated diarrhea. Probiotic supplementation can reduce the diarrhea episodes and improve gut microbiota composition. Okay, these are the some example I can observe uh, we can see the benefit observed in other patients put inside the ICU and critical patient.